And I'm delighted to introduce the chair of the session, who's also the speaker, who's going to give a presentation on identification and management of MetALD. Luis Diaz Piga is actually from Chile, is a friend and a friend of work with Mark Aresi, who's also a close friend of ours, but currently a professor at the UCC, working very closely with the fatty liver. He is really a star in the field of SLD, but specifically in the area of MetALD. So we're delighted to have Luis come and give us a presentation on MetALD and then run a panel that we will be talking about some of the issues. So Luis, welcome.
Thank you, Zobair, for the introduction. And today I will speak about the identification and management of MetALD. This is my disclosure. And today I will specifically speak about the burden of chronic liver disease. Dr. Younossi already mentioned it before in early morning. Also describe this new definition of MetALD in the 2023 criteria. Also, I would like to show you what are the leading mechanisms of liver injury in MetALD and provide evidence in the assessment and the main specific interventions that we could use in this setting. So, in 2023, we had a change in the nomenclature, and now we have a framework, an umbrella of steatotic liver disease. And MetALD is basically the overlap between MASLD and ALD. And this definition considers very arbitrary thresholds, and that's a reality for sure, but give us an opportunity to start assessing people with steatotic liver disease and increase alcohol intake. So it's defined with an intake by grams per week between 140 and 350 in women and 210 and 420 in men. So this forces us to start assessing better alcohol intake, because if we don't assess alcohol, unfortunately we cannot make an adequate diagnosis of MetALD. So this is just a reminder that we need to establish how many drinks people is consuming in the daily living, not only weekends. And we also need to convert that definition into grams. And in the US and the rest of the Americas, we usually use 14 grams as a standard drink. And in terms of global epidemiology, there's only scarce data, and most of that data came before 2023. But a recent systematic review estimated the prevalence of MetALD in around 4% of the adult population and in around 10% of people with steatotic liver disease. If we see the global distribution, unfortunately, there's a lot of heterogeneity in the estimations of the MetALD prevalence, but you can notice that in Asia and some countries of Europe, we have a higher prevalence of MetALD, but in Mexico as well. And this heterogeneity can be driven by the different clinical settings, but also the underreport of alcohol intake. So we need probably more information to have better conclusions about the global epidemiology. And if we see what's going on in the US, the MetALD prevalence is estimated in around 2.6%. And the distribution of liver fibrosis between MASLD and MetALD, it's quite similar. And if we also see the leading indications of liver transplantation in the US, MetALD is one of the most important indications for liver transplantation, and currently it's the third cause of liver transplantation in the US. So this is a very important disease, and it's very frequent in the clinical practice as well. But it's important to highlight also that people who have risks for steatotic liver disease can have an increased adiposity, insulin resistance, and the insulin resistance will generate lipolysis from the adipose tissue, releasing free fatty acids that will induce hepatic steatosis. But unfortunately, alcohol can promote those mechanisms, but also alcohol have their own mechanisms of liver injury in the liver. So alcohol have direct effects and in terms of de novo lipogenesis, and toxic effects can at least generate an additive effect in severity. And this is what we see in this figure. It's very important to notice that cardiometabolic risk factors are important, but alcohol use seems even more important in terms of the severity of steatotic liver disease, especially in MetALD and ALD. It's also important to notice that alcohol intake can induce a rise in the blood pressure and also in the triglycerides, and that can be a confounding factor for the diagnosis of MASLD or MetALD. And as Dr. Younossi mentioned before, diabetes and obesity seems the leading drivers of liver injury and progression over time in this setting, and for sure, alcohol intake. So, for clinical practice are three main aspects that we need to address in all patients with MetALD or suspected MetALD. And the first one is the alcohol intake. I mentioned in the beginning of the presentation that we need to ask about the standard drinks or the number of drinks that people drink over the week and estimate in grams per week how much patients are drinking. But we also need to assess other dimensions of alcohol use, including the presence of addiction to alcohol, and that's the alcohol use disorder, that are linked to alcohol intake, but they are not synonymous. They are going the same road, but are not exactly the same. So you need to know how much they are drinking, but also if they have an addiction to alcohol or not. And we can use some questionnaires like audit or other techniques. And also you need to know if patients are drinking every day or if they have a binge drinking. We still need more data to know if a binge drinking can be more harmful or protective. The data is not so conclusive about the risks, but it's important to know because we need to establish targeted interventions in the alcohol intake in this population. And also, it's extremely important to ask about the exposure to alcohol use over time. It's not the same drinking 10 years than drinking 10 days, yeah? The second aspect will be the cardiometabolic risk factors, and finally, the stratified liver fibrosis risk. We have discussed about the underreport, and this was mentioned in the MASLD session, but it's important to notice that around 10% of people in clinical trials tend to underreport alcohol intake, and this can be up to 55% in clinical practice. So novel strategies, or not so novel, but we are incorporating them now, like alcohol biomarkers has been used to identify underreport. And phosphatidyl ethanol, it's one of the most promising biomarkers to identify undisclosed alcohol intake. And this is a study that demonstrates that phosphatidyl ethanol, or PEth, it's a better predictor of survival and the compensations over time in the patients with ALD, and even better than self-report alcohol intake. And since we know that alcohol and active alcohol intake, it's the leading risk factor for mortality in this setting, this is direct evidence showing that phosphatidyl ethanol is a good marker of alcohol intake. We also have some data from UC San Diego. This is a study including the San Diego liver study cohort, and my colleagues demonstrated that a phosphatidyl ethanol over 25, it's a good cut point to identify MetALD in the steatotic liver disease population. And when we use a threshold of 35, this has 90% specificity for the diagnosis of MetALD. We further perform additional analysis, and when we use phosphatidyl ethanol to assess alcohol intake, in addition to self-report alcohol intake, we identify that PEth can increase the MetALD diagnosis up to 4 times and the ALD diagnosis up to 3 times. And we know that this is a very dynamic process, and some people is heavily drinking, and the following months they stop drinking, or they notably reduce their drinking. Or other people who were within the MASLD category, they tend to increase their levels of alcohol intake. And this change can be up to 60% in the MetALD and ALD population. So that's why the current steatotic liver disease definition, it's good enough as a framework to start identifying people, but we know that there are some aspects that we need to also incorporate in further process of definitions or classifications over time, including the dynamic changes and the prior alcohol exposure. So, in my perspective, we need to change the order in which we identify MetALD, because the nomenclature proposed starting assessing the cardiometabolic risk factors in people with hepatic steatosis, but probably we need to start asking about alcohol and see if this alcohol consumption is inducing or not metabolic dysfunction. And we can also incorporate phosphatidyl ethanol, especially if we are unsure about the alcohol intake. And this can help us to identify the different populations, including those with MetALD and ALD. And for sure, incorporating biomarkers is a good opportunity to ask about alcohol and maybe reassess alcohol intake more closely, especially for the clinical implications. This is a landmark study that was published 2 years ago and was very famous when we started talking about MetALD. And this study basically assessed the number of cardiometabolic risk factors and the different levels of alcohol use. And you can see that in the MASLD population, even low levels of alcohol intake can induce a higher risk of significant fibrosis. And if you pay attention to those with just one cardiometabolic risk factors, when they drink alcohol, even below the threshold for MetALD, they have a 12.8% of significant fibrosis versus 2.2 in those who don't drink alcohol. So alcohol can amplify the severity or the liver injury in this setting, in MetALD, but also in MASLD. So that's why it's so important to do an adequate assessment of alcohol intake. Well, we assess alcohol now, we need to stratify risk. And there's no many data about risk stratification in MetALD, but we know that non-invasive tests are good enough in MASLD and ALD, so probably they will work very well in the MetALD setting as well. And this is a study that, by using MRE, demonstrated that FIB-4 has an adequate performance, especially a high non-negative predictive value to rule out fibrosis. And we also performed a study in San Diego demonstrated that the clinical pathways by using FIB-4 and a FibroScan also have a low false negative rate for significant fibrosis. So probably clinical pathways won't change in this setting, at least during the following years, but there's no many data about the therapeutic strategies. For one side, we need to address alcohol, and probably If we know that those patients already have an alcohol use disorder, we need to follow the pathway of the management for alcohol use disorder, including behavioral therapies and pharmacological therapies, and maybe refer those patients for an integrated management. We also need to pay attention to the nutrition and exercise. We discussed that in the MetALD section, and the recommendations should be similar, same for weight loss. But there's a lot of room for new therapies to consider in this setting. And probably the use of resmetirom sounds an attractive option in this setting, especially in those with a more metabolic predominant phenotype in MetALD. And there's some data that was presented in an ASLD conference demonstrated that those in the Maestro trial who have a positive biomarker for alcohol have the same response to resmetirom. And other medications that can impact in the liver injury, but also in the alcohol consumption, can be very relevant in this setting, including the incretin-based therapies and FGF21 analogs. Unfortunately, I performed a search in clinical trials a couple of weeks ago, and I just identified 6 results for MetALD. And unfortunately, only 2 of them involve clinical trial or the assessment of a therapy in MetALD. So probably perfect is the enemy of good, and we need to translate the evidence in people with MASLD and active alcohol intake into MetALD, and the same from the evidence on ALD. This is the ESSENCE study that was showed in the past presentation, and you know that semaglutide in a dose of 2.4 milligrams per week can induce a MASH resolution and also an improvement in liver fibrosis. But there's also evidence showing that semaglutide can induce a reduction in the alcohol intake and also an improvement in the cardiovascular risk over time. So probably the incretin-based therapies like semaglutide and others can be attractive options to be used in MetALD, but we need more evidence to provide a strong recommendation. And for FGF21 analogs, you know that they have important metabolic effects, but also can induce a reduction of alcohol intake. So we need more evidence with this kind of medications in MetALD, but I think that can be very promising. I would like to finish the presentation showing some recent data on the natural history of steatotic liver disease, especially in MetALD. And you can see that people with MetALD are at higher risk of liver-related events over time compared to MASLD. And when we see the cardiovascular disease, this is very similar to the people with MASLD. So individuals with MetALD are exposed at the same cardiovascular risk that individuals with MASLD, and that's a very important aspect to address in the clinical practice. And I think these presentations make me think that we have more questions than answers, and probably we need more observational data and also better clinical trials in the field. Probably we need to identify how many patients with MetALD we need to include in the MASH trials. We also need to validate the 2023 definition for MetALD. Probably we need to assess the surrogate markers that better predicts the liver-related events in the MetALD setting. And probably we need to identify pharmacological treatments, because this is a very frequent steatotic liver disease subtype in the US and the rest of the globe. So I would like to conclude that the global prevalence is estimated at least at 4%, but it's probably underestimated and it should be even higher. And it's important to have a comprehensive metabolic risk assessment, especially for the cardiovascular risk of this population, but alcohol intake evaluation is a must in clinical practice. And we need to assess the current drinking, including the intake in grams per week, the drinking patterns, and the exposure to alcohol over time. And we incorporate, maybe in all liver clinics, we can incorporate PET, because this can be very helpful to identify patients with MetALD. For now, the non-invasive tests should be the same that we are doing for MASLD and ALD. And lifestyles modifications are extremely important, especially targeting the reduction of the alcohol intake. And we need further data in the pharmacological therapies, but we can use the next session to discuss about that aspect. Thank you so much, and thanks for your attention in this topic. I would like also thank to organizing committee for making me the chair of the panel discussion. So I would like to invite again Dr. Manal Abdelmalek, Dr. Scott Isaacs, and Dr. Zobair Younossi. They were already presented. Probably they don't need presentation, but I really appreciate your presence here. So maybe we can also turn on the lights so people won't be sleepy, and this will be also an interactive session to discuss different topics involving MetALD. I would like to invite people to make questions in the microphones, and thank you. Now we can see us. So we can start with the questions.
Thank you. Stavros Synthakos, Cincinnati, a very informative talk. How well or how accurately does PEth predict binge drinking or episodic drinking?
Well, I can get that question. There's some data in healthy volunteers that you can have one single binge drinking. PEth will be detectable or the peak will be in around 8 hours. And you can detect that binge in up to 8 to 12 days. It's not the same window of detection that can be up to 4 weeks, but a binge can last up to 12 days.
Hey, nice to see you, and wonderful talk. Congratulations on all your work in PEth. So how do you incorporate this in practice? So is it part of your standard abnormal liver chemistry evaluation that you draw a PEth level, just given its contribution not only to the fibrosis in MASLD, but candidly to every liver disease that we see when we evaluate people in clinic? And should it just be, we order many things, Hep B, Hep C, et cetera. Should we just put PEth out there? I have a panel just for that now, although it's not always well received.
Thank you. I think it's a very important question, so we can start with the opinion of our panelists, and I can also provide mine. So
maybe I can sort of talk about this a little bit, and I'll be interested in what you both think. From my perspective, liver diseases don't exist in isolation. There is not just isolated hepatitis B or hepatitis C. We always thought about this, but it's just not true. What we are seeing more and more is that hepatitis C exists with metabolic abnormalities, so does hepatitis B, so does, and also alcohol. So I think every patient that comes in requires at least not only the sort of liver disease that you're dealing with, that assessment for viral hepatitis, for example, but also two other diseases or two other components of progression of the disease. One is actually cardiometabolic risks, and the other one is alcohol. I personally would actually favor, we need to get more data, of course. I'm just talking about this as an opinion because there is just no data to state that. We do know that, for example, cardiometabolic risk causes more aggressiveness of viral hepatitis. We know that. There's been plenty of data. But in terms of how much alcohol can be also additive, at least my suspicion is there is significant additiveness to this. So I would recommend that moving forward, that we would do this, that we would understand the underreporting of alcohol is not unique to MASLD, that's also for viral hepatitis and other areas. What do you think, Manal?
I agree completely. I consider it as a cofactor for disease progression independent of the liver disease. So I will check a path for every new consult that comes to our liver clinic. And with elevation of liver enzymes in situations where I didn't otherwise expect it, even in patients with autoimmune hepatitis whose liver enzymes go up and they were otherwise stable, I'll check a PET test. And I consider it like any other cofactor. We talk with our patients about alterations in diet and exercise and decreased soda consumption. We should be talking to them in the same light about alcohol use. It's unemotional, it's unbiased, it's not implicating, any stereotypic, labeling. And I talk to you about diet, I talk to you about risk factors. Alcohol is a risk factor, and we check it in the same way we talk about anything else.
Louise, does the level of PET gonna change if you're talking about, say, another disease like viral hepatitis, or you still have to go with a cutoff of 20 or 35, whatever you use? What do you think? Would that be an issue?
Well, to complement the response, I agree that it's a very important aspect to assess in clinical practice. Alcohol can increase even the incidence of hepatitis B and C, and also we show the effect in people with metabolic dysfunction. So it's important to all people with chronic liver disease. And PEth, it's a very nice marker because don't depend on the underlying liver disease. It's important to understand that PET, it's not a completely quantitative biomarker, so you cannot correlate exactly the number of standard drinks with the values of PEth. But at least in those up to 80, you can have a mild correlation. My message is, if you have a PEth over 25, I think that's a very good opportunity to discuss with the patient. Hey, I think this can be maybe more significant that you mentioned it before, and that can open a discussion. 80 probably is a really increased or very relevant exposure to alcohol intake, and over 200, that's probably diagnostic of ALD.
I think the main purpose of PET from an endocrinology perspective is basically are our patients telling us the truth, and we know that people are not honest about alcohol use in their history, and so it's really helpful. But on the other hand, we can get into some pitfalls with it, and patients can get a little bit upset if it's ordered without telling them. It comes off on the lab profile. It says drug monitoring template. And so I always tell my patients that I'm measuring PEth and what it is. And I also tell them, like what you're saying is, it doesn't tell us how much alcohol you're drinking. What I tell them, it tells us how the alcohol is affecting your body. And I think when I present it that way, it's a little bit easier for them to accept and agree to getting the test done.
I totally agree. And it's important when you get a PEth testing, use a non-stigmatizing approach to the patient, because you need to correlate that PET with the self-report alcohol intake, and that's extremely important. You cannot interpret a PET without those prior questions. Maybe someone had a wedding last week and the PET gets positive, or maybe someone is heavily drinking. You don't know unless you ask to the patient. And it's very important how you approach them. This is not to accuse them. It's just to complement and establish an additional treatment that can be very helpful to prevent progression of liver disease. Next question.
That's an excellent meeting, and I bet you, Nikhil, PET will be positive for some of us next week, but perhaps the following will not be. So I don't see this as an one-point check. So if we would like to be more granular, we need to have actually a longitudinal follow-up on the PET. Something that I would like to ask is, how well has been the microbiome studied for patients with MetALD, and what's your opinion about the autobrewery syndrome that can increase the PET And after that, you say you are drinking, and the patient says you don't know what you are talking about. Any comments on this, please?
Yeah, probably when you have a positive path, you need more than just enthusiastic microbiome to increase it, right? But I totally agree that the exposure over time is probably the most relevant factor, because the liver has important clearance in terms of hepatic steatosis. So if you have a binge drinking last week and you have 4 weeks without alcohol, probably you won't have hepatic steatosis in your tests. So when you have a persistent hepatic steatosis and alcohol, it's probably a more significant exposure. And it's also important to mention that the levels of alcohol intake don't exactly correlate with the liver injury, because we have a lot of susceptibility, and it's probably the same susceptibility than muscle D. I don't know if you want to.
The only thing, the only thing that I would comment on PET, and maybe you should comment too, is that there are all these kits, especially in the research side that's being sold, that actually quote unquote measures PET on serum. So I think that's an issue that we need to, clarify that that's really not validated, and people are spending money for nothing. And the second thing is that, you need RBCs, and the RBCs has to be either in room temperature or -80 in order to actually get accurate this thing. So my understanding is that if you put it in -20, it actually, you destroy sort of some of the performance of PET testing. So some nuances that as we are going to get more and more PET testing in the clinic, that the clinical sort of staff needs to know.
I also think you raised a good point about content of use, right? So a PET test in a patient with cirrhosis in my clinic means a lot different than a PET test in, a 20-year-old or who just is, in college with maybe simple steatosis and no liver injury. So having some contextual context and how we use it for counseling in relation to the severity of their liver disease and their comorbidities is exceedingly important.
I totally agree. It's important, and there's no data in terms of the use of PET over time. Some European countries have been using PET for many years, but we don't have granular data in liver disease. But I totally agree, and probably the effect on people with advanced fibrosis will be extremely relevant, or people with decompensated cirrhosis. That people needs a negative PET, hopefully, but if not, it's as we mentioned before, it's a good opportunity to intervene and prevent more decompensations.
Any comments on the auto-brewery syndrome and how does this affect, because the PET can be positive over there as well, which is relative to the microbiome?
Yeah, as far as I know, there's no evidence about a huge increase in alcohol biomarkers in this syndrome. Some colleagues at the UC San Diego are enthusiastic in that topic, and we will probably have more data at least here at the San Diego. But probably even if you have a positive PET, I think the main question is to ask your alcohol behavior, and also when you have a positive PET, probably you are taking alcohol. It's the most typical false positive is transfusion of blood. That's what's really described in the literature.
Hi, very nice talk and panel. I came up here initially to the microphone to discuss further the dynamics of getting PET tests. I first want to, and Dr. Isaacs niftily preempted me by going into a very nice discussion of it, which then I think Manal made a comment also, very helpful. I still want to know if it's clear to all of us that we should get consent, not written consent necessarily, but we should at least inform patients we're getting a PET. Do we all agree on that? You don't do a PET without telling the patient you're doing it, because I think that's a recipe for disaster potentially later on. So if we all agree on that, we still have a span of patients, a spectrum of patients who are very different from each other. There's a patient who sits very earnestly and tells you very plausibly and believably that they never drink, or they have a few drinks a year. And for the most part, I haven't been fooled by patients like that subsequently. I wonder if we have to test each and every patient who comes through our doors. The spectrum also includes people who say they drink a moderate amount where it may really be helpful. And then the one bad experience I had, Paul also mentioned, that it, quote, doesn't always go over very well, was a patient in whom it was pretty obvious from both his history and the clinical picture that he was a heavy drinker. I asked him if we can get a PEth test, and I did exactly what you said, Scott. I told him it wasn't to test his veracity, but to see how much it's accumulating and what the dynamics can be different from one patient to another. And that was essentially the end of the visit. And I'd like to think I know how to handle these things, but it did shake me for a few hours, and I still think about it as an unpleasant memory. Can you just elaborate a little bit on how you modulate the language of getting the PEth test for these different patients across the spectrum I've described?
Thank you for those comments. That's really good, and I think that's really sort of informative. Probably a lot of us have had that experience, but in endocrinology, if you end up diagnosing alcohol-associated liver disease, sometimes there's embarrassment. Sometimes they don't want to come back and see you. Sometimes they say, I want my primary care doctor to take over management. But I think it's a sensitive area, especially when that's, at least in endocrinology, that's not why they're coming to see you. And so I would admit that sometimes I don't always do it when I think I should. And I do rely on the patient history probably more than I should.
And I think it's extremely important from this point, because the stigma, we're doing a global stigma study for ALD. There is such a stigma associated with just quote unquote excessive alcohol use and alcohol sort of issues that it actually could be counterproductive, as you said. So I think people like you who is in the field and others, and we need to really have a better approach, a guidance to clinicians of how to really address this, so it's not going to be, a disincentive or stigmatizing patients in terms of, having now alcohol in the middle of this disease. The only advantage of non-alcoholic fatty liver disease term was that once you made that comment, they thought, well, I'm not at least alcoholic. So those are the kind of things that need to understand in the context of stigma.
And, I think the rapport that we have with patients is incredibly important. If a patient's going to be so forthright with me to tell me that they're drinking 4 to 5 drinks a day, do I need a PEth? No. Mm-hmm. And if somebody's, and their wife or husband are sitting right next to them, I never have drank and have never been a drinker, do I need a PEth? Probably not, because, there's some confirmatory reporting there. That gray zone in between, I do talk to my patients and say, I'm really not sure how much your social alcohol use is playing a role in your liver disease. Let's check and see, and have that dialogue. But do I get it every time? I really think it depends on how forthright I believe my patient to be and accurate their reporting is.
Okay, great, thank you.
I think it's also important what we discussed before, that alcohol intake needs to be assessed in all chronic liver diseases in adults, not only in MetALD or ALD. Otherwise, we are losing an important fraction of people exposure to this risk. It can be up to 10% or even more in people with hepatitis C. And probably we can identify an alcohol intake between 5 to 20% in other chronic liver diseases. So it's a good opportunity. And when you do or establish this assessment in all conditions or all chronic liver disease, you are reducing the stigma, because you're not stigmatizing just people with MetALD and ALD. And if you see that most of clinical trials in alcohol use disorder, they still rely in self-report alcohol intake, craving, and other questionnaires. So even PEth is very valuable as a tool. It's just an additional tool to what we have to do in clinical practice, is to sit down with the patient, ask them, and build a good relationship.
Yeah, there has been an interesting situation or two in my clinic where a patient clearly has significant alcohol use disorder, and I will use the PEth. They seem to be responsive to a change in their PEth score over time that's declining as positive reinforcement for their attempts at abstinence, almost like a weight loss program. You know, come in, you get weighed in, you lost weight, great, your semaglutide is working, or they come in and their PEth test is dropping over time as a positive reinforcement for their efforts and earnestness with alcohol interventions. I don't know that there's any data to support its use in that kind of manner. But I have had, hey, did my PEth test drop? I've been abstinent for 3 months. I'd be interested in other people's perspectives on this.
For sure.
Okay, Brian Lee from Los Angeles. So really congratulations on the session. Super interesting topic. And PEth particularly, we've seen an explosion of its use in the past several years. One use of it that I've struggled with was in the setting of blood transfusion. And I haven't seen much data on that, so I'm curious as to your experiences, if we know much about the kinetics of blood transfusion, and where this has come up a lot is in the pre-transplant setting, where we've seen patients with very, very high PEth levels, and they really say that they haven't drank at all, and then we see that they receive the blood transfusion, but we've generally said this is too high to really be plausible, but this is actually come up several times now, so I wonder, is there something with blood transfusion and PEth? So could you comment on that?
Thanks, Brian. Well, I think it's there's only a few articles assessing, and there's no many data about the kinetics and the impact, but the main message, at least, I think it's important to don't do PET testing after you started a blood transfusion and wait up to 4 weeks to reassess alcohol intake. It's difficult when someone was transferred from other center and you want to have a more strict assessment of alcohol intake, or someone it can collaborate for an assessment for liver transplant. But if you have a PEth over 200, probably that's not from the transfusion. Probably it's for the self-intake. But we need more data to support different thresholds in that setting.
Yeah, I think we don't know. It's come up several times, and I use PEth all the time. But I think more and more we have to be cognizant, even in the absence of transfusion, that we don't know much about the kinetics of PEth actually. So I think when we're using it for negative clinical consequence, I don't know if the data is quite there yet.
Yeah, I agree with you, and there are several specific settings that can be very difficult. For example, someone who gets admitted with hepatic decompensation can collaborate, and you get a PEth testing after transfusion, and it's positive, and you're thinking about a living donor liver transplant. So what will you do? So yeah, I think that's a very interesting area to have more data.
Thanks.
Thank you.
I would just want to start by thanking the panel and also Luis for an excellent presentation, and I think a very important discussion. And I wanted to come back to something that you mentioned in your presentation about getting audit C or audit questionnaires from patients, because I think when we do get PEth testing, and there probably are some settings clinically where it's valuable, it should not be done without coupling it to a formal, structured interview approach to getting quantitation as best you can from self-report, because I think in the isolation, it's not as meaningful. The second thing I wanted to do is to come back to this comment that Brian made about the kinetics of PEth and ask your thoughts about this, because I know that in the initial development of PEth testing, one of the problems is that there's a lot of individual variability in the half-life of PEth. It's not the same for each person. It's very individual, and it's not even necessarily the same in one individual every time. So this is not a very straightforward test when it comes to thinking about it from the pharmacokinetic perspective. So your thoughts?
Thank you. I totally agree with the first point, and that's why it's extremely important to have a clinical assessment and a comprehensive assessment of alcohol intake before getting and interpreting a PEth. Also because if you get a positive PET and you ask after and you do the questionnaires after, the response can be also affected by the value of the PET, or patients maybe have a low PET and also can modify their answers. So I totally agree. And in terms of the half-life of PET, yeah, it's better than other biomarkers in terms of a window of detection. But yes, someone could have a binge drinking for 2-3 days, or someone could have a heavy drinking and stop 2 weeks before, and they can have exactly the same path. Or someone who have a binge drinking and stop can be detected, as we mentioned before, almost for 2 weeks, but others just for 1 week. So it's not perfect, and that's why it's extremely important for clinicians to understand that this is an additional tool. It's a wonderful tool because we don't have many tools to assess alcohol and increase awareness about alcohol in chronic liver disease.
Yeah, and I think it performs great in the research setting, but I think the comments that you all have made are ones that really should make us think a lot about how we're using it in clinical practice. Thank you.
Thank you. The next question.
Thank you so much for your talk and this panel discussion. I had a question. And we know that alcohol cessation is a powerful tool in ALD. And I was wondering, kind of in your practices, what you've noticed in sort of alcohol cessation in helping with patients with MetALD, and whether or not you concurrently kind of try to implement MASH-directed therapies at the same time, or focus on the alcohol cessation first and reassess, and sort of timeline of reassessment.
Thank you. I don't know if you want to start answering.
I do both concomitantly. If a patient has clinically significant fibrosis, I mean, the discussions surrounding alcohol are as a cofactor are significant. We have a digital remote monitoring program for any patient with alcohol use at Mayo. So they get support from a nurse who'll check in with them. I refer them to any resource that they are open to participating in. And I will treat also their MASLD MASH in the context of their MetALD as I otherwise would. I don't necessarily restrict that or withhold that pending alcohol, cessation. But if you have more significant alcohol use, I may take it in stages. But I have found that particularly with GLP-1, I can kill 2 birds with 1 stone almost, and so I won't withhold therapies.
Just a couple of things. I think in terms of lifestyle management, I don't think it actually is different than MASLD, because these are not ALD patients, so and probably don't have alcohol use disorder. So we have to do the same thing. We have to address the cardiometabolic risk. We have to address alcohol and have exactly the same approach. The question I have for you, Louise, and also you, Manal, should we encourage pharmaceutical industry to stop thinking about alcohol exclusion of our patients? Because, even in the Madrigal trial in resmetirom, a few of these patients were actually turned out to be the 8%, turned out to be MetALD or even more. And the efficacy was exactly the same, so it wasn't that different. So maybe we should actually not have sort of this cutoff, or maybe a lower cutoff for alcohol. What do you think as we develop this, and especially in the context of the duals or GLP-1 receptor agonists having also alcohol sort of impact? What do you think?
I have strong feelings about this.
Okay, well, you talk first then.
My strong feelings is you didn't write into your inclusion criteria less than 7 sodas a week, and you didn't write into your inclusion criteria must be on a Mediterranean diet for 6 months prior to enrollment. I really think if your drugs are going to be clinically applicable and worldly and relevant, the patients that are included in the study should appropriately reflect the population who's going to be using your drugs. Now, I can understand excluding those patients with higher risk for acute alcoholic hepatitis, and maybe that PEth is greater than 200, or I don't know what thresholds you would use, maybe 100, but the paradigm of not alcohol is gone. It's been gone. We're dealing with metabolic liver disease, and as I strongly feel, alcohol should be treated the same way as soda, which should be treated the same way as a Western diet. It is bad. It's all bad. But let's not call it out independent of every other environmental exposure.
And not only agree with you about alcohol, I also think that the pharmaceutical industry and the clinical trials have done a very, very poor job in assessing diet and lifestyle changes. You look at any clinical trial and you try to actually get history of, how much ultra-processed food people were actually consuming. Can't find it. Or how much activity people have. For this disease, if you don't actually capture that, that data, and then you wonder why there is placebo rate, well, you know that some of it is probably related to either alcohol consumption or change of the diet and all that. And I think this is something that we should encourage our pharmaceutical colleagues to not only actually assess alcohol and make sure that there is more better assessment, but also of diet and activity during clinical trials.
Yeah, and we seem to have forgotten that fructose consumption is associated with not only fatty liver, but in a dose-dependent manner, fibrosis progression. So that's no different than alcohol, and fructose will induce endogenous alcohol, based on the sugar load in the gut microbiota. So we're not purists here.
Yeah, I agree, and probably we need to incorporate people with more active drinking in the clinical trials, probably not those in the highest level, because the alcohol will be the leading driver of liver disease. But what can pharma do? It's just subgroups analysis, but totally agree. We just have a couple of minutes for 2 questions, so Ashrani, please.
Yeah, I think I'm standing here and listening to all this comments made by panel and everybody. Makes me feel good because for a long time we have been thinking about alcohol as a driver of liver disease, the commonest liver disease worldwide, if I can use the word. Makes me think better because the excitement and discussion going on, maybe the organizer should think moving the alcohol section up front when we start the meeting to drive the discussion, something to think about. Let me bring about 2 comments here. The comment I think Zobair made about how you address alcohol use. As physicians, I think we are learning how to address removing the stigma and overcoming the stigma when we talk to these patients. So stay tuned for the session on alcohol liver disease, where we will talk about that. And I think we're still learning. We don't know exactly how to deal with these people, whether they are primary care doctors or internists or even gastroenterologists, hepatologists. I think this is something to training. It requires a lot of addressing this alcohol use disorder with these patients. The point I'm bringing, which again I think the panel raised about how to address research and clinical trials in MetALD, the topic of discussion. And I want to bring the other part. We know the underreporting part of alcohol. We don't know, do people over-report alcohol? And there may be individuals who say, okay, I drink 5 drinks or 6 drinks, something in the category of alcohol-associated liver disease, but when we check PEth levels, whether this is over-reporting or, like Max said, pharmacokinetics of PEth, the PEth levels may be in the range of MetALD, like 20 to 200. Where you will put this patient, in the ALD category or MetALD category, especially when you're trying to do a clinical trial? I don't know the answer.
Well, I think it's a relevant aspect, and we need more data especially for the clinical trial settings, because I review the evidence on PEth in the last month, and there's no more 15 articles in the last year with the steatotic liver disease definition, assessing PEth and different changes over time, and at least with interventions and other things. So I think it's a very important aspect to address, but in the same line that we discussed.
But I want to thank you for running the session so well, and your talk was excellent. Thank you very much.
Thank you. And probably we need to work collaborating together in CLD Foundation, ASLD, ESL, and other organizations. The last question, please.
Okay, thanks. So this is an excellent session. I wish Manal wasn't so shy about giving her opinions. But aside from that, there are just two quick comments. One is pharmaceutical companies have one goal, and that is to get the drug approved. So you can't blame them if they try to make the path easier. That's a difficult question, because in a company, if I want to succeed, I want to get the drug approved no matter how I do it. And so there are a lot of other factors and a lot of other people involved that could contribute to that decision, but it's not entirely the companies.
That's absolutely right. There is nothing that's going to kill a drug more than the concern of DILI. Quote, it may not even be real DILI, it may be alcohol, but there's nothing that's going to kill a drug over that concern. All I think the industry needs to reflect on is really, we have never historically, in any MASH trial in 30, 20 years, measured PEth, or evaluated systematically alcohol use in a validated manner, or had the time to do it. It just was not on the radar screen.
Right.
The reason the FDA would kill a drug is the concern of DILI, and they will assume DILI unless you could prove otherwise.
Right.
And we saw drugs fail because of the lack of quality data, because of a liver enzyme signal that nobody could explain.
Right. So the cleaner the study, the easier it is to see the endpoint. And the other thing, maybe I misinterpreted this, but in speaking to a patient about PEth, I don't like the idea of saying to them, I'm testing to see what the effect is, because if they look it up, they're going to say, you were lying to me. I think you just have to be brutally honest with the patient. Say, Jessica Mellinger gave a talk where she said, she just tells every patient who comes in, I'm going to check you every time for PEth. If you don't like it, this is not the clinic for you, because I think you just have to say, I'm here to try and help you. I need all the data. I'm always going to support you. I'm not being judgmental, but this is a fact of what we're going to do every time. And I think you should probably, it's expensive, so it's kind of an annoying factor, but I think you should have a blanket rule that says it's every time, and you're going to get that in your inbox the day it comes back to me. Thanks.
Well, thank you. As I mentioned before, probably we need to work through different organizations to face the stigma and try to avoid the stigma in steatotic liver disease. And I would like to thank everyone for attending this session, and thanks to our panelists.